Dear doctors, in this video I am going to discuss questions related to EDIC Part 1. In this video I will be focusing on questions related to nephrology, it means acute kidney injury, CRRT and the monitoring of renal patients. Let's move on.
Question 1. A 65-year-old septic shock patient on norepinephrine develops oliguria. Urine output less than 0.3 milliliter per kg per hour for 8 hours. Serum creatinine rises from 1.2 mg per deciliter to 2.1 mg per deciliter. Which of the following best defines his acute kidney injury according to kidney disease improving global outcomes criteria? Stage 1. B. Stage 2. C. Stage 3. D. No AKI. Indeterminate due to vasopressor use. Correct answer is option A. Stage 1. The kidney disease improving global outcomes staging for acute kidney injury categorizes severity into 3 stages based on increase in serum creatinine or a decrease in urine output. Stage 1 is an increase in serum creatinine of 1.5 to 1.9 times the baseline, or an increase of at least 0.3 mg per deciliter within 48 hours, and or AA urine output of less than 0.5 milliliter per kg per hour for 6 to 12 hours. Stage 2 involves a serum creatinine increase of 2 to 2.9 times the baseline value and or urine output of less than 0.5 milliliter per kg per hour for 12 hours or more. Stage 3 is a serum creatinine increase of 3 times the baseline or to 4 mg per deciliter or higher, or the initiation of renal replacement therapy and or urine output of less than 0.3 milliliter per kg per hour for 24 hours or anuria for 12 hours. Question 2. A patient with rhabdomyolysis and acute kidney injury required continuous renal replacement therapy. The ICU team chooses continuous veno-venous hemodiafiltration mode. Which statement best describes solute clearance in this modality? Clearance is predominantly by convection. B. Clearance is predominantly by diffusion. C. Clearance is achieved by both convection and diffusion. D. Clearance depends only on the ultrafiltration rate. Clearance is negligible for small molecules. Correct answer is C. Clearance is achieved by both convection and diffusion. Explanation. Continuous veno-venous hemodiafiltration combines hemofiltration means convection and hemodialysis means diffusion both. Small molecules or solutes are cleared effectively by both mechanisms, while larger molecules depend mainly on convection. Question 3. During continuous renal replacement therapy, the filter frequently clots despite appropriate anticoagulation. The effluent rate is 35 milliliter per kg per hour. Which of the following is the most likely contributing factor? High blood flow rate. B. Low filtration fraction. C. High filtration fraction. D. Use of regional citrate anticoagulation. Pre-dilution replacement fluid administration. Correct answer is C. High filtration fraction. Filtration fraction is calculated by dividing ultrafiltration rate by plasma flow rate. High filtration fraction means filtration fraction more than 25 to 30% causes hemoconcentration within the filter leading to clotting. Solutions include reducing filtration fraction by increasing blood flow, or using pre-dilution fluid, or reducing ultrafiltration rate. Question 4. A patient on regional citrate anticoagulation on continuous renal replacement therapy develops rising total calcium and ionized calcium ratio more than 2.5. What is the most likely cause? Hypocalcemia due to citrate toxicity. B. Citrate accumulation due to hepatic dysfunction. C. Excess calcium infusion. D. Hypomagnesemia-induced citrate binding. Filter calcium leakage. Correct answer is B. Citrate accumulation due to hepatic dysfunction. Explanation. Citrate is metabolized in the liver and muscle. When clearance is impaired, citrate accumulates, binding calcium and causing elevated total calcium but low ionized calcium. Hence, Ionized to total calcium ratio more than 2.5 indicates citrate accumulation or toxicity. Question 5. A patient with septic shock develops acute kidney injury. The nephrology team recommends starting renal replacement therapy when certain criteria are met. Which of the following is not a generally accepted indication for initiating renal replacement therapy? A. Refractory hyperkalemia. B. Severe metabolic acidosis with pH less than 7.1. C. Oliguria for 24 hours. D. Pulmonary edema refractory to diuretics. Uremic complications like encephalopathy or pericarditis. Correct answer is C. Oliguria for 24 hours. Explanation. Oliguria alone does not mandate renal replacement therapy on its own, unless associated with metabolic or fluid derangements. The other options are classical, evidence-based indications. Question 6. In a patient receiving continuous renal replacement therapy with regional citrate anticoagulation, which of the following best reflects adequate anticoagulation within the circuit? Systemic ionized calcium 0.9 to 1.1 millimole per liter. B. Circuit ionized calcium less than 0.35 millimole per liter. C. Total calcium ionized calcium ratio less than 2. Serum bicarbonate more than 24 millimole per liter. Filter calcium more than 0.6 millimole per liter. Correct answer is B. Circuit ionized calcium less than 0.35 millimole per liter. Citrate chelates calcium within the circuit, preventing clotting. Effective anticoagulation is indicated by post-filter ionized calcium less than 0.35 millimole per liter, while maintaining systemic ionized calcium within normal range. Question 7. In a hemodynamically unstable ICU patient with acute kidney injury and intracranial hemorrhage, which renal replacement modality is most appropriate? A. Intermittent hemodialysis. B. Sustained low-efficiency dialysis. C. Peritoneal dialysis. D. Continuous veno-venous hemofiltration. Continuous arteriovenous hemofiltration. Correct answer is option D. Continuous veno-venous hemofiltration. Explanation. Continuous veno-venous hemofiltration provides gradual solute and fluid removal, minimizing hemodynamic instability and intracranial pressure fluctuations. Ideal for patients with brain injury. Question 8. The patient on continuous veno-venous hemodiafiltration with a blood flow of 150 ml per minute, dialysate flow of 25 ml per kg per hour, and replacement flow of 25 ml per kg per hour receives all replacement pre-filter. What is the likely impact on solute clearance? A. Increased solute clearance due to dilution. B. Decreased solute clearance due to reduced concentration gradient. C. No change in solute clearance. D. Increased clearance of protein-bound solutes. Increased urea clearance but decreased creatinine clearance. Correct answer is option B. Decreased solute clearance due to reduced concentration gradient. Explanation. Pre-dilution reduces solute concentration entering the filter, lowering effective clearance despite preventing hemoconcentration. Post-dilution gives better clearance, but more clotting risk. Question 9. In acute kidney injury, which biomarker rises earliest and may predict kidney injury before creatinine increases? Serum cystatin C. B. Neutrophil gelatinase associated lipocolin. C. Interleukin 6. D. Kidney injury molecule. E. Beta-2 microglobulin. Correct answer is option B. Neutrophil gelatinase associated lipocolin. Explanation. Neutrophil gelatinase associated lipocolin rises within 2 to 4 hours of tubular injury, preceding creatinine. It is a sensitive early biomarker, especially in ischemic or septic acute kidney injury, before functional decline manifests. Question 10. A 55-year-old man with septic shock and acute kidney injury is on norepinephrine and continuous renal replacement therapy. Mean arterial pressure is 65 millimeters of mercury. Which statement regarding renal perfusion monitoring is most accurate? Mean arterial pressure 65 millimeters of mercury or more ensures adequate renal perfusion in all patients. B. Renal autoregulation is intact in all septic patients. C. Dynamic indices like renal Doppler resistive index may help guide therapy. D. Increasing mean arterial pressure beyond 85 millimeters of mercury always improves glomerular filtration rate. Central venous pressure accurately reflects renal perfusion pressure. Correct answer is option C. Dynamic indices like renal Doppler resistive index may help guide therapy. Explanation. Septic acute kidney injury often involves loss of autoregulation. Static measures like mean arterial pressure or CVP do not reflect microcirculatory perfusion. Renal Doppler resistive index and renal perfusion pressure derived from mean arterial pressure minus CVP can better assess real-time renal blood flow. Renal Doppler resistive index can provide real-time, non-invasive information about renal perfusion and vascular resistance. Studies suggest that index can help predict persistent AKI, assess response to fluid challenges and vasopressor titration, and may help determine individualized mean arterial pressure targets.
Dear doctors, here I finish. I believe these questions were useful to you. See you in my next video on some very interesting questions. Till then, bye and take care.